Good afternoon, ladies and gentlemen. You are welcome to this webinar focusing on emerging infectious disease. Mohammed Lamodi from the Infectious Diseases Institute of Makerere University. Dr. Mohammed is the head of department of the Global Health Security Program, and he has worked with the Institute since 2006, focusing on clinical pharmacology research, health system strengthening, and he also directs several projects focused on health security, including Global Health Security Partner Engagement Project for Uganda, working together with the Centers for Disease Control in the US, as well as the being part of the Uganda Country Response Grant funded by the Resolve to Save Lives. And he leads Infectious Diseases Institute contribution to the Joint Mobile Emerging Diseases Intervention Clinical Capability project, which is an international consortium. So Dr. Mohammed comes with a lot of experience in that area, as well as in research. And so we are privileged to have him present today. We request that you write your questions, any questions that you have, you write them in the Q&A section. We'll be able to read out those questions so that they can be answered. We are delighted to see all of you joining us from various countries and various continents. So you are very welcome. The objective of this session is to really help the palliative care fraternity to properly appreciate the issues around infectious diseases, because we find ourselves in the middle of that situation, and more especially within the African context, because we have had a number of outbreaks. We've had Ebola, we've had Marburg, and now we have COVID-19, and several others that break up, as we will hear from Mohammed. So please welcome with me, Dr. Mohammed, to make this presentation. And as I said at the beginning, please write your questions in the Q&A section, and then we'll have those answered. We are delighted at the African Palliative Care Association to host this webinar, and we hope it's just a beginning. And this is the second webinar we are hosting since the outbreak and the lockdown we've had in a number of countries. So please sit, relax, and prepare to learn from this session. Don't forget to write the questions in the question and answer section. Dr. Mohammed, you are very welcome to take over the presentation. Thank you very much.
Emmanuel, thank you very much first for the invitation and this opportunity. I have had not that much interaction with the African Palliative Care Association, but I remember two things. And one, was in training. When I joined IDI, there were sessions that we held at your facility on end-of-life care. And then the second opportunity I had was interacting with your team during the country's preparation of a palliative care policy for Uganda, as well as a training program. And so there were several interviews, and the African Palliative Care Association has made a very significant impact as far as the way the country functions. My goal today is really to highlight some of the things that have been happening. I'm not going to talk about everything that is happening, say, at national level, that I think is beyond our scope. But what I wanted to show was what an institution or an organization can do within the context of a response. and really highlight, hopefully towards the end, opportunities that the African Palliative Care Association can also engage in. And I'll be very happy to take questions on the approach at the end of the talk. So to start with, the issue we are having is something called zoonotic spillover. And it's happening more frequently. We have a situation where new diseases are coming and then old diseases are coming. People think about conspiracy theories and say, oh, are these viruses that are attacking us created in the lab? But the reality is that we have so much diversity from nature that the fact that we haven't had many more of the outbreaks like what we're seeing now with COVID over the last 100 years is more of good fortune rather than preparedness. If you look at the countries here, these are just examples of outbreaks that have been reported recently. You have everything from monkeypox. Monkeypox was a virtually forgotten disease. The last time we were talking about monkeypox, I think, was in 1979. But in Nigeria, we've had monkeypox over the last 2 years, and some of those cases were successfully exported to the United Kingdom and other parts of the world. So even our ability to spread those types of diseases that we don't hear much of is really there. We have Lassa fever also in Nigeria. Nigeria has a population of nearly 200 million people. And with Lassa fever, we see a disease that is not so much of one animal passing it to one person and that person passing it on to thousands of people. But we're seeing a situation where many rats are passing this disease to many different households. And even if you think about how you're going to trace and identify who has the disease, you find that your public health measures are really constrained because you can't go and say this is the last person that was infected and therefore, the other person that can be infected is the person that was in contact with him. You actually have to message across the population on keeping premises clean and avoiding contact with rodents. We have yellow fever, Ebola, plague, and these are all cases, these are also zoonotic diseases. And if you look at Uganda alone, we've either had to investigate or respond to these in the last 12 months. So at any one time, if you look at the world, there is a zoonotic outbreak happening. The issue is whether we contain it or whether it spreads. And so the question is, how prepared are we to prevent spread? Now, there's a global framework around this. The reality is that countries signed up to something called the International Health Regulations. And this is a legally binding treaty that the WHO uses to ensure that all the countries that are members of the World Health Organization ensure that they can prevent epidemics within their territory, they can detect them early, they can respond rapidly and effectively. But if they are not able to contain this themselves, they have mechanisms in place to alert their neighbors and the global community so that the world can come together to confront some of these threats. But the global health security agenda was set up when it was realized that countries were not making progress to IHR 2005. Basically, countries had deadlines to meet minimum capacities, but that did not happen. And so this is an initiative of countries, but even private sector organizations, academic organizations to come together and figure out how do we accelerate progress towards ensuring that each country within its territory is aware of its responsibilities and is competent to respond as needed. And so the funding from this initiative is really targeted at strengthening several countries' infrastructure. Now, countries really basically have to choose to join. And those countries then get opportunities to strengthen their programs, their national response programs, and the funding has to be done really taking government, putting government at the heart of it. Government is really responsible for protection of life in any country or territory, and ensuring that government is capable of protecting life is a critical aspect of GHSA. There are many different action packages for the GHSA, and these are just priority areas that were selected. So for example, if you have labs in your country, those labs need to be safe. For one thing, you don't want lab staff going and getting contaminated and infected. And at the same time, you don't want people accessing your lab and picking potentially dangerous pathogens and doing crazy things like terrorism with it. And so you have things like a biosafety and biosecurity system that countries must have. Countries must know what zoonotic or diseases that spread from animals to humans are circulating in their midst. We have to think of not just the short term, but also the longer term threats like antimicrobial resistance, and even have things like a vaccine delivery system. If we got a vaccine, say for COVID-19 today, and countries needed to vaccinate, say, 15 million people in a period of, say, 1 month, how many countries have the logistic capabilities to get that done while maintaining, for example, a cold chain? In Detect, you have lab systems, you have disease surveillance. These are like investigators or detectives that go and help figure out where the outbreak is coming from so that you can put the resources there to contain them. Reporting both within country and internationally is critical, and training programs must be active to ensure that you can build up the size of the workforce that you need for the type of outbreak that you have. So it has to be scalable capacity. There are things like medical countermeasures. We talk about that every day. You know, is there a cure for COVID-19? You know, you see that in the news, you hear of hydroxychloroquine. But you actually need the systems also to ensure that you can deploy those products within your country. You know, if your country, for example, wants to access a drug like remdesivir, is there an easy way for the regulator to bring those drugs in? Can you also bring in personnel if needed to ensure that you can deliver these treatments? Uganda, I think, has a stellar example of an emergency operations center, and it has worked very well for over 10 years. It's been supported by the CDC directly. And so you have this central coordination office where when an outbreak happens, you can quickly set up an incident management team and then really track. But the question about this presentation was preparedness. Now, COVID-19 came as a surprise to many people, you know, and the impact, I think, was what was even more surprising. I don't think people are so surprised that outbreaks happen, but I think people were surprised that an outbreak could shut down the travel system, the government system, you know, in many countries very quickly. And so the question is, how prepared are we for this outbreak? And how prepared are we for future outbreaks? I'm not going to spend too much time. I think that we get too much information on COVID, but over 4 million cases are present, and there have been over 300,000 deaths. And this is a disease that we've only known for about 5 months. In a sense, it's new because the virus in particular is new. But the reality is that we have been expecting something like this for a long time now. The last time we've had something like this was over just about 100 years ago. And, you know, it was clear that you could have diseases spread via the respiratory route that could devastate countries and communities. So it's not our first time experiencing a deadly outbreak that is spread, you know, through the respiratory route. But I think that because of the long gap between that outbreak and this one, we may have been a bit less coordinated than we ought to be. But the truth is that, you know, countries are aware that this is a risk. And the way I'm going to frame this is that let's take an example of 2 countries. And one of them is Vietnam. Vietnam has more than 97 million people. It's located very close to China with solid transport links. It's a former communist country as well, so really well integrated with China. And then let's look at Uganda, about 45 million people. And both of these countries have, you know, less than 400 cases. Both of these countries have 0 deaths, and they are surrounded by countries that have, you know, bigger outbreaks. These countries are considered, you know, countries that have acted quickly and aggressively. So the question we have is that, was it a mistake, or is this just by chance? And I think that while there may be many other factors in play, something to really think about is that When the Global Health Security Agenda initiative was started and countries had to volunteer to participate, these two countries were amongst the first countries to open up their systems to a pilot evaluation. Actually, the tools that we use have been refined based on the original assessments that were done in these countries. And these countries also benefited from a lot of the early investment in terms of event-based surveillance in Vietnam, and a lot of capacity building has happened with US government funding in Uganda. So could it be, I guess, the question is, could it be that in the last 10 years, these countries have really invested more in terms of training workforce, in terms of responding quickly to outbreaks, and perhaps even the leadership that is present in these countries is the same leadership that enrolled these countries in the health security agenda. And that might be part of the reason why their responses look different. And so emergency preparedness is about having a plan. It's not just about having a plan, one has to maintain that plan. And we talk about, risk mapping, where we look at the hazards that are present, but you also look at the vulnerabilities that a country has. So let's give a good example is, if you talk about Uganda, a good example of a hazard is Ebola. So Ebola is a hazard in Uganda. Now, if you wanted to map it, you would say Ebola is located outside Uganda, close to the on the other side of the border with the Democratic Republic of Congo. But because Ebola has happened before within Ugandan territory, and we know the locations where Ebola has been detected in the past, we know that there are places in Uganda where Ebola can happen. The same goes for Marburg. And one way to do that type of mapping has been to simply map, for example, the bats, where the bats are really located in Uganda, and identify locations where we think that there can be transmission from the bat, which is the animal, to the human. So the zoonotic transfer that we've talked about. We also need to think about the vulnerabilities. So we know that these bats are there and something could go wrong. They can come in contact either with a person, or there could be an intermediate pathway where maybe they come in contact with fruit and then the human being comes in contact with fruit, or they come in contact with another animal, the human being comes in contact with that animal. So there are vulnerabilities. Vulnerabilities can be low risk perception in the population. Vulnerabilities can also be that the health system itself has low infection prevention and control, so that when the suspected case comes in, it's transmitted to healthcare workers even before you make a diagnosis of Ebola or Marburg. But when you've done that, you also have to think about the resources that you have. You need to map out those resources. For example, have healthcare workers been trained for containing outbreaks? Where do you have access to logistics, resources in the country system? Can you utilize existing platforms within the country to scale up your response? Can you even work with partners that are not typical response partners and bring them on board at the time of need to help accelerate your response? When you've done all of that, you have to test your plan. And your plan should not be tested just in the Ministry of Health alone. You really have to focus on all the people that are involved in the implementation of the plan. So we talk of multi-sectoral involvement. And this is what we expect a country to do. But really, emergency preparedness is happening on many levels. So at the WHO's level and global partners, they also are thinking about emergency preparedness. And they've assigned roles and responsibilities, say, to United Nations agencies and also to international partners that bring them direct support, such that they can cascade that type of guidance rapidly to countries and sub-regions so that those countries can pick them up. At the same time, it is less than the national level. Outbreaks are not happening at our emergency operations centers. They're happening in communities, they're happening in families, they're happening in health facilities. And so we need to think about the plans at those levels. And if you're an organization or an institution, your ability to contribute even to a response is often driven by the preparedness that you have to even continue your business operations as an institution. So while we talk a lot about national level, there are many other levels, and all of us actually need to be thinking this way. I wanted to use this example to show you how some types of risk assessments are done. Now, this is an approach known as PopCab. And what it does is that it looks at the people that are on one side of the border, and then it finds out what they do when they cross the border and come to the next country. And why we did this was we wanted to know where we would prioritize our interventions for Ebola virus disease, assuming cases from DRC of Ebola were crossing into Uganda. So we wanted to know the schools that the communities would normally use if they crossed the border and came to Uganda. We wanted to know the places of interest they would go to. For example, we were able to identify that there was a specific hotel in Kampala that people would use as a rest stop when they're coming from DRC, but heading all the way to Kenya. And so you could go to those locations and facilities and either provide information or even potentially conduct surveillance if you suspected that the disease was spreading in that way. The output of this exercise is to generate risk maps. And these risk maps show us the patterns of movements. And then the local governments can use those patterns of movement for their local planning. And then national governments can also be aware of these and use it to coordinate their efforts. So these are some of the types of risk assessments that you would see being done in countries. And right now, in the southwestern part of Uganda, we are doing the same thing in terms of movement from Tanzania into Uganda. So what does it mean when you have a country plan? It means that your systems for coordination have been identified, you have trained personnel, you're able to mobilize your material and supplies to respond at the earliest indication of a pandemic. And it's based on the principle that if you respond early, you could save lives. Now, I'm not going to underestimate what a global pandemic like COVID-19 can do. There are some people that have argued, I'm sure many of us have heard of flattening the curve. And some people even go ahead to argue that when you flatten the curve, you don't necessarily reduce the total number of cases, but what you do is you extend them over a longer period of time so that you don't overwhelm your health system. But the truth is that if you got an outbreak at the very, very beginning, then you have a strong opportunity to actually eliminate it. And we know, for example, New Zealand is reporting that they don't have any local transmission that they're aware of. You know, it is something that can be of benefit. Going very aggressive at the beginning, preventing any cases, could potentially delay the outbreak in your region until you're able to get proven interventions. And then that could then lead to a reduction in the, in the harm that the disease can cause. When you have a plan early, it also means that you have an opportunity to mobilize resources. Governments often struggle with generating domestic resources for large-scale outbreaks. But when they go to international donors, the donor says, show us your national plan. Now, preparing a national plan when everything is falling around you is actually very hard. Ideally, countries should be able to develop this document within 2 weeks. In practice, many countries within a month don't have a final plan that is available. And that really delays the ability of the partners to go in and fundraise and then bring those resources back after they've gotten approval to respond to the outbreak. So many times we're talking about 3 to 4 month delays before countries can see any significant amount of resource. But if you had the plan already, that would just be tweaked. For example, you would just delete everywhere you wrote pandemic influenza and replace it with COVID, share that with partners, and then your response starts moving. So let's bring it down to an organization. In IGI, where we work, when we realized that this was happening, we didn't have a plan for COVID-19 because COVID-19 didn't exist. But we had already identified pandemic influenza as a risk to our organization. It's actually in our top 10 strategic risks, that an outbreak could happen that could not only impair our operations, but could actually affect our staff in terms of welfare, and they could transmit that to other staff or in the community. And so we had a template really to quickly work with. We quickly deleted pandemic influenza, replaced it with COVID-19. And then we have 3 levels. The first level is, we said, okay, there's the risk present, but we don't have evidence of transmission. And basically we would continue with a monitoring approach, but identify a specific coordinator for the organization for COVID-19 to engage with the Ministry of Health and IDI staff and ensure we had ongoing information. We also use that time to establish communication channels and as well as educational activities within the organization. So we use that to make sure that people were aware, people had early training with whatever information was available, either from WHO, from the Ministry of Health. We try to make that immediately available. In level 2, we said we would, have a scenario where there will be some cases in country, but it will be apparent that the country is doing sufficient to contain the spread. And so basically, this is where you go to once you have the first case being reported in the country. And our plan was then to ensure our board of directors were aware, we were following social distancing guidelines, we were providing training to service providers. And then we started to implement things like teleworking for at-risk staff and staff that had respiratory symptoms. And then for some of our programs, and I'll show examples, we started to do in-house drills to ensure we could continue services in those areas. Now, the red part obviously is the bad part. And this is if there is active and sustained community transmission. And we know that this could paralyze operations quite quickly, especially in some of the areas that we work in. And so, we would have an escalated protocol in terms of ensuring social distancing, as well as ensuring that we restrict who goes into office premises. So what did we do internally? As I said, looked at case conferences, journal clubs, ensured that presentations were happening quite regularly. Infection prevention and control training. We identified staff that had been working on voluntary male medical circumcision. We knew that these staff understood the principles of infection prevention and control and identified them as a potential group that could be used to scale up IPC interventions where the outbreak to become worse. Finance and administration has to make a plan to secure its supply chain. And the supply chain is not just COVID-specific things like PPE, but when you have disruption of business systems, you really need to be talking to your suppliers to ensure that all the other things that you routinely need will still be available. And here we have a photograph of a clinic drill. And basically, this was on a Wednesday when the clinic was light. People came out, and then we had to act out scenarios of how you can run a clinic and minimize the risk to healthcare workers. People. As the head of the program, when an outbreak like this happens, people expect the head of the program to lead. But reality is that you will have many gaps in many areas, and what you really need to do is to multiply yourself as much as possible. And because you can't do that, you have to work with people. And so giving responsibilities to people and allowing them to grow into those responsibilities, there is never a better time than a global pandemic. And so we have Solomon Okware. She's been based at the Ministry of Health, helping the country track progress through Resolve to Save Lives on meeting its IHR, International Health Regulation obligations. But during COVID, she was then moved to support the incident management team, support the ministry in terms of communication, and support the drafting actually of the country preparedness and response plan. We have Peter, who sits in the situation room. He's a pharmacist by training, but he sits in the situation room monitoring calls that are coming in, ensuring that alerts that are coming in are responded to, and really ensuring that committees that are there are able to meet using Zoom and other kinds of technologies, so that the hundreds of meetings that need to happen keep going. And then Roger Zayebare is a certified infection preventionist at IDI. And he had been working mainly on Ebola, and then we channeled him to focus on COVID. And he was able to identify, recent publications that were been used in China for triage, and then adapt that for resource-limited settings. And his paper actually got published in the Lancet Respiratory Medicine. And these are the kinds of assets that you need to build during an outbreak. By simply being part of an outbreak response, people gather long-term career skills that can help both the organization they work for, but also for their own individual career development. Something people don't really think about is that, you know, if you didn't have a disease before, then that disease is not known to law. I mean, this is an interesting concept. You would have a Public Health Act, but a Public Health Act would apply to the diseases that were written when the Public Health Act was designed. I know Uganda's Public Health Act is decades old, and so COVID-19 was not known to law. So one of the first things we did through Funding for Resolve to Save Lives was to review the Public Health Act, and then where it says something like syphilis, etc., and other infectious diseases, you now have to create rules that stipulate that COVID-19 is one of those other infectious diseases. And this empowers the country, whether the Ministry of Health or the government, to institute lockdown measures that are legal. Otherwise, people can come back and sue the government and say, because of your lockdown, I lost a family member, etc. We should feel free to embed technical support and staff at national committees. Often partners are waiting to be invited. The correct thing to do is to introduce yourself and say, this is what you do, and you would like to know if there's a committee that is available that you can contribute to. There has to be capacity building for laboratory testing. This has been going on worldwide in the news. I'm not going to label that point, but also in terms of surveillance. Supplies are always a challenge. Partners can create buffer stock. I wouldn't say partners take on full responsibility, but you can create buffer stock and work within your country systems to see how best buffer stock should be used. If you do create buffer stock, the government needs to be aware you have it. And if you deploy it, the government needs to know where you've deployed it. And this helps to minimize duplication of efforts. And then each country is going to be different. And whenever WHO comes up, say with training material that is global, it is often difficult for them to calibrate where each country is at in terms of their health system. And so participation in the adaptation of guidelines is absolutely critical to ensure that whatever guidance we're giving to health workers makes sense. Now, communication and technology. Uganda set up a specific pillar for information, communication and technology, ICT, but it also has a separate pillar for risk communication. The principle is this: when an outbreak is new, there's a lot of misinformation, there are a lot of myths. The World Health Organization describes this as an infodemic. It is potentially damaging to response. Our role as partners is to amplify the government's messaging. If there is one time when you must listen to government, is during a pandemic. That's really not the time when you debate the issues. During a pandemic, the countries that are most successful are countries whose citizens follow government instruction. And so some people have called it open authoritarianism that happened in Vietnam, where because this is a country from communist stock and they had a very strong social interaction with the population in terms of control, and that they were able to bring the community to comply with guidance and virtually eliminate cases in the country. What we did at IDI was to find out where the funny information is coming from. And the encrypted platforms, I think, are the most worrying to me. And this includes things like WhatsApp. There are a few other encrypted platforms. What this means is that government cannot see what is happening there. And so we don't know the messages that are happening in that system. And yet WhatsApp is very widely used. There have been hundreds of myths from this is caused by Bill Gates, or this is a biological warfare from China. But most of the times, these things are unhelpful in terms of the response that is present in front of us. And so what we've been spending time doing is educating people on those platforms as to what a reliable source of information is. And after a while, initially you get a lot of posts, but after a week or two, people start auto-correcting. You find members on the platform talking to each other and said, no, but that's not a reliable source of information. And that's really where you want to go. And every organization that has a WhatsApp group, for example, can play that role. And it's part of the work we are seeking to expand to ensure that we have many WhatsApp groups that can help ensure that only that people are aware of the sources of verified information. We prioritize healthcare workers. And the reason why we prioritize healthcare workers is because if a healthcare worker spreads a rumor and the people that receive the rumor on WhatsApp know that this is a healthcare worker, they are more likely to believe, even if that is false information. And so we worked with not just IDI staff, but staff in the regional referral hospitals that have been designated as COVID treatment centers. And in all, there are over 400 people that are on those applications. We've also been implementing a technology that had been used for HIV really to remind people of their appointments, send people calls, people can actually report symptoms through it. And that was modified with funding from Johnson & Johnson to be able to call people every day and with a pre-recorded message, ask them if they've developed COVID-like symptoms. And then all they need to do is type yes or no, press 1 for yes, press 3 for no. So you don't even need a smartphone, just a regular phone that has a keypad with 1 for yes and 3 for no is enough for you to be able to communicate. And that has been used for contact tracing of over 600 people in Uganda. We have to think about research when we don't know what we are dealing with. COVID-19 looks like a typical respiratory outbreak, but now we know that this is nothing like influenza. While influenza primarily targets some organs, COVID attacks the heart, it attacks the kidneys, it attacks the liver. We know that this is not just a respiratory pathogen. And that means that we would need to think out of the box also when it comes to treatment. Now, this program called JMedic is about 4 to 5 years now in the making, and it set up a clinical research team in Fort Portal Regional Referral Hospital. This is the largest regional referral hospital in Western Uganda. And in that facility, the team, they work on a daily basis on, a sepsis type research program. But one day a week, they think outbreak. So they're managing critical illness and observing the course of critical illness during the week. Then on Fridays, they come out and they perform drills specifically to manage filovirus cases. So that's either Ebola or Marburg. And that means they're able to use a very high standard of personal protective equipment. But at the same time, they also have skills for research. So if you were to introduce, for example, a new drug into the country, or you wanted to test the efficacy of that type of drug, you actually need a team that both understands clinical care, understands infection prevention and control, but also understands the principles around ethical research, which is challenging during outbreaks. We have to get IPC systems right. This is, before you even think about what's going to happen in the health facility, you have to start thinking about administrative and engineering controls to ensure that people with the disease do not mingle with people without the disease in areas where you have crowding. So if you had a health facility, you would typically see about 40, 50 people in a waiting area. What you don't want is somebody with COVID right in the middle of that, and then the person coughs once, and then you have about 15, 16 people who came to health facilities for something else, developing COVID. And so triage systems, having clear pathways for people with respiratory infections, ensuring that you're reinforcing respiratory hygiene and hand hygiene. And if somebody does have symptoms and you identify, you immediately give them a mask. Masks are quite effective in reducing how much virus a person can spread to people around them. At this point, you now have to start thinking more about PPE. The beautiful thing about level 1, and I think this is something that we all must realize, I think often healthcare workers are disempowered because they feel that they have no PPE. I keep emphasizing that the two most valuable assets you have are time and space. And the principle is simple. If I can stand away from a virus or a pathogen long enough, and that pathogen needs me to survive, the pathogen will eventually die, and then I move on happily. And so the distancing is absolutely critical. If we have the right level of social distancing, this virus will disappear, and you do not need any PPE for adequate social distancing. But when you do start things like screening people or interacting with people that could be sick but you're not sure, you need to increase the level of PPE. If you're providing care to people that have COVID, you don't need just a mask, you would even need a face shield, gowns, etc. And then in level 4, you would need what we call an N95 mask, or a mask that can really reduce the kind of particles that can penetrate. And this is really when you're performing procedures that can generate aerosols. This is everything from intubation or cardiac massage. Currently, these are healthcare worker protocols, but currently, countries are making different choices. And one of the choices countries are making is to use cloth-based masks in the community setting. Now, this is not recommended in the healthcare setting. There haven't been enough studies to show that there's benefit. In fact, there is concern that if you keep a cloth-based mask for long, it gets wet and actually may pull in infections rather than protect. But I do know that it's possible that some countries might be considering cloth-based masks even for healthcare workers. If you do hear of that, I'll be glad to hear more about it. But the evidence that we have to date does not support cloth-based masks for healthcare workers. So, planning in terms of resources, we have to stick with what the medical masks that we have. But for the gowns, there is sufficient evidence that you can use reusable gowns and even potentially reusable foot covers if necessary. This is not easy, and I put it right in the title. You need to check on your employees. If somebody is providing care in a COVID treatment facility, then there should at least be a register that says this person came in at this time, the temperature was normal, the person had no symptoms. That's just an occupational health basic. But we need to look to the future and think about all other locations, and can we use technology to say, send people SMSs and say, look, if you develop any symptoms, please call this number. And when they call that number, somebody's at the other side of the phone to take them through a risk assessment, know whether they've been exposed in the facility or in the community, determine whether they are high risk or low risk, and whether they need to just self-isolate at home or if they even need to get testing. This will boost confidence in the health system and ensure that we're able to continue this, this fight. Case management is challenging. We did not design our health systems for advanced care. We designed our health systems in developing countries for primary health care. And for people with severe disease, we know that critical care facilities are absolutely vital. This means upgrading infrastructure, means making holes on walls so you're not carrying cylinders in and out of COVID wards. It also means people who may not have been typically intubating and ventilating patients would need to be trained quickly to start providing critical care. But there are other things that are not so expensive, and we're learning more about things like, conscious pronation, which means you aim for an individual with mild to moderate COVID to spend more time in the prone state rather than in the supine state. And by doing that, we seem to see that there is better oxygenation, and it might actually reduce the need for intubation in some patients. So we need to be thinking, what are these clinical strategies that can be used that don't cost much money, but can help to reduce the strain that we have in terms of our health facilities. Now, we want to work hard, to set up our case management platforms based on global standards, but we know the resource constraints that we have. We also know that even in the most advanced countries, when you allow COVID to overrun the health system without appropriate social distancing, mortality is still high. And so if you're hearing over 1,000 people per day dying in a developed country with advanced ICU mechanisms and lots of trained staff, we should be under no illusion that our numbers will be just as high if we don't apply adequate social measures. So non-pharmacological interventions like social distancing, ensuring hand hygiene, etc., must be the mainstay of our response. Every effort should be made to avoid making the health facility the theater of battle, because even with intubation, we know that mortality still remains very high. But at that point, if we do get to that point where we see a lot of death, then we need to also look at other resources that are available in the country. And, the African Palliative Care Association, if you've been listening to a lot of people, and I've had a personal experience too, where you lose a loved one, but because of the COVID situation, for example, the family is not able to grieve normally. You're not able to do a safe, participate in burials as would be needed. The end of life care for people may not be optimal if everybody is afraid of them in a health facility. And there is that place really, I think, for APCA to really engage and understand, how things are happening and what needs to be done to reduce suffering for the person that has the disease, but also reduce suffering for their family and their loved ones. And with that, I thank you.
Thank you very much, Dr. Mohammed. We are really very appreciative of this presentation. It opens eyes of especially the palliative care fraternity, who are not strongly exposed to what you've just shared with us. But let's go to the questions that have been posed. Maybe you could help answer some of those questions. We'll start with a question that came from Kenya, and is asking Asaf Kinyanjui from the Kenya Hospice Palliative Care Association is seeking guidance on what percentage of the country's GDP should be allocated to emergency kitty. The second bit to his question is how civil societies can be involved in creation of awareness, given what you've just shared. And then the third section of his question is, how do we cushion the vulnerable from the financial impact of epidemics, of pandemics within the African context? And he's asking whether it's by promoting saving culture or establishment of circles. So that is from Kenya. The other question that we have is from Kennedy. I think it was from Kennedy. He put it on the questions about how robust the case hello? Dr. Muhammad, are you there?
Yes, I am.
Yeah, he was asking about how robust the case detection in Uganda is, and wanted you to say something about the testing centers in Uganda, how many there are, and how long it takes to get the results when people are tested. So I think we can start with those questions, then we'll go to another round of questions.
Absolutely. So, I mean, the first question is, what is the percentage of the GDP that should be allocated to the emergency kitty? the measure that is tracked is whether or not a country has a system to rapidly access funding during outbreaks. So the quantity of money may not necessarily be specified, but the issue is whether there is a system where the country can, say this is a basket that we can use to access those resources. And believe it or not, that often is the most challenging part, because countries need to often accurately budget for everything they are going to spend in a year. And so you would expect that there would be a dedicated basket fund in the Ministry of Health for outbreaks and emergencies. Right now, Uganda, for example, doesn't have that. But what is available is a national contingency fund. But that is really for all disasters, whether it's health or landslides, earthquakes, etc. The key issue, as I said, is having a system, a clear system for being able to request for that money and getting that approved and getting money released. That is really the stumbling block for most countries. Now, could the dominance of the pandemic in the upper hemisphere of the world explain something that maybe we countries are missing in the fight? We've had, different, I can't say we know everything here, but what we know, for example, is that travel connections in the northern hemisphere is actually much stronger than, for example, number of flights from China to Uganda. And therefore, if an outbreak is being seeded by people traveling on planes, then it's more likely that the countries where those planes went to will have a bigger outbreak than the countries where the planes don't routinely fly to. It is possible that there are other factors. People have talked about genetics, but when you look at, for example, Black people in the US, even when you adjust for everything, they seem to have a higher death rates than say Caucasian populations. So we don't think there is a genetic protection per se. There may be other things that are explaining it. Even if it were a genetic issue, that genetic benefit would be distributed within all populations, including Black populations, which means some people will be resistant and some people will be susceptible in every race. So I think we want to look at it based on, the number of cases that actually got into Africa and then the ability of those cases to build. But what we see is that in some countries, these numbers are rising fast. How do civil societies create awareness to the community? Now, if government is spreading the wrong information, the role of the partner is to go to government. We do not compete with information with the government. We work with government to ensure that the right information comes out. Anything else can make the outbreak worse, because if you make the communities lose faith in their government, then when the government comes later with something that they really need to do, like take vaccines, people may not access those vaccines. So we help the government reframe the messages and improve, rather than creating parallel outbreak systems. The financial impact on the pandemic is the biggest challenge now. Countries must keep people in maximum social distances for as long as it takes to reduce the numbers to such low levels that it will take a long time for a new outbreak to come out. We don't think you can completely eliminate it once it has been established. But if you keep it for very long, you can actually reduce the numbers. This is exponential increase to very small numbers, such that it takes, it will take much longer, say from 100 to double to 200 than it takes for 10,000 to go to like 100,000. So we need to think really at that. Ben Ochan's question is similar to the social one. Countries have to have a plan. It is not easy, but if you want to keep people in lockdown, they cannot be hungry. So I would leave that as the responses to these questions.
The other question that came through the chat from Kennedy was about how robust the case detection system in Uganda is. the number of testing centers we have, and how long it takes to get the results?
So Uganda has, in my opinion, a robust testing system. Uganda has been tracking infections from using a traveler approach right from the beginning of the outbreak. And so what has been happening is, you identify all the people that have been recent travelers, you identify their contacts, you identify contacts of those contacts. You ask them to come in for testing. Anybody is positive is isolated and managed. Multiple mechanisms were used to do that. When you layer on top of that effort, lockdown and social distancing, it makes it very difficult for the virus to spread. Now, the next obvious issue was that even if Uganda stopped the outbreak very quickly, from the airport areas, people are still moving through the land borders, and not all countries around Uganda may be using the same approach. And so Uganda instituted testing for truck drivers coming into the country. And really to turn around those results became a challenge because the number of truck drivers can easily go between 2,000 and 3,000 per day. The testing centers at the Uganda Virus Research Institute. There's a Makerere lab that also received accreditation to test. And then there's CPHL, which recently received about 15,000 kits. And they have a cobas machine that can do 3,000 tests per day. But the issue is not just the testing capacity. You must have the reagents, for the tests that you're doing and the kits. So if you have a machine platform that can test 3,000, samples in a day, and then you run out of your 15,000 kits, in 5 or 6 days, your testing capacity goes down. What we will say is that there have been, challenges, but when testing becomes slow, what Uganda does is that it adds a new lab. So they added 40,000 tests with the Makerere lab. They've added 15,000 tests with the CPHL lab. And then there's also gene expert machines that are being placed at the borders, but with fewer numbers of tests, so that you can get an instant result at some of the border places. But the 3 central labs that I know that are actively operating would be the 3 I've mentioned. There is plans to build capacity in a few other labs as well. Testing turnaround time can be as little as 1 day, but it can take as long as 3 or 4 days when the system is trained. And so we are really happy to see some of the testing really done directly at the border.
Thank you very, very much, Dr. Mohammed. I don't know whether there is one person who can just ask a question directly. If there is one who can wave, give that opportunity for somebody to ask a direct question, and then we close at the top of the hour. Is there such a person who would like to ask a direct question? I think there is one more question that has come in from Atupere Piri. In such instances of outbreaks, I feel it would be better for WHO or similar organizations to take lead globally by using country organization representatives than government ministries. This would streamline the uniformity of response and improve the response in a way. What do you think? Otherwise, countries are responding to the pandemic with different perspectives. Dr. Mohammed, would you like to say something about that question?
Truthfully, I mean, that is what is that's the plan, isn't it? That the WHO, they even set up this pandemic emergencies program, to do exactly what you have said. The challenge, of course, is that countries are sovereign. They choose to be part of WHO and they can choose to withdraw from WHO at any point in time. So what that does is that it gives politicians a lot of power. What WHO does is to use its diplomatic channels to ensure that they can bring ministries of health on board and influence governments to follow the right guidance, but they cannot necessarily force a government to do what it doesn't want to do. So to me, I think the effort really should be preparing people, educating people long before these outbreaks on what preparedness and what a right response looks like, so that when it does happen, people are playing out a script rather than seeking approval for each activity from government. But it's discouraging, as you have said, when you see different countries doing completely different things.
Thank you very much. And our last question is going to be directly from Eve. Eve, you have the microphone now. Please go ahead and place your question. No, I think we can't hear Eve's question because of the connection there, I think. Let me take this opportunity to thank everybody who has joined us. We, in a special way, thank our colleagues who have joined from the different continents outside Africa. Thank you very much for joining. Thank you very much, Dr. Mohammed. Our next session will be building on exactly what you've presented, so that as palliative care providers, thank you very much, everybody, and God bless you.